Hello everyone, I am Dr. Shruti Devi, Gynaeconco Fellow in Narayana Health City, Bangalore. And today on the day of World Cancer Day, we are continuing our discussion about various cancer treatments. And in this session, we'll be discussing about the gynec cancers. And to do that, with us we have Dr. Rohit Ranade sir, the consultant gynecologist and robotic surgeon, Narayana Health City, Bangalore.
Hello everyone.
And Dr. Jayanth Bhargava sir, the consultant radiation oncologist, Narayana Health City, Bangalore. Hello sir.
Hello.
Hi. So, cancer is one of the most common causes of morbidity and mortality, and among the women, there are a lot of cancers, especially the cervical cancer, endometrial cancer, and ovarian cancer. And cancer cervix is the second most common cancer in women in the world, and also in India. And let us discuss something about the cervical cancer. So, what are the risk factors for cervical cancer, and what are the symptoms of cervical cancer?
Absolutely. Thank you, Shruti, for bringing out this topic. I think, as you have already said, cervical cancer is the second most common cancer in women in India, and it is unfortunate when, as a country, we are advancing into with more and more research. It is still unfortunate that there is a death because of cervical cancer every 1 in 8 minutes. So it's very important for the general population to be aware of cervical cancer, and it's good that we are having this discussion on this forum. So coming to risk factors of cervical cancer, now we know that the causative agent of cervical cancer is a virus known as the Human Papillomavirus. So there are some risk factors like early marriage, childbirths at smaller intervals, then most important, maintenance of hygiene, and these are some of the risk factors, to name a few.
So, what are the signs and symptoms of cervical cancer?
Yeah, so most of the patients who come to our OPD are, they come with complaints of bleeding per vaginum. So basically, it could be excessive bleeding either at the time of menses, or it could be bleeding in between, or it could also be bleeding after having sexual intercourse. So that's the commonest. There are other symptoms, like there could be some whitish discharge. Patients coming with advanced disease could present with some pain in the lower abdomen, pain in the back, sometimes some issues with passing urine and passing stools. So these are the commonest kind of presentations that we've seen.
So what are the tests available to diagnose cervical cancer?
So the most important test that we have to do is, first, patient comes to us with these symptoms. The most important thing that we need to do first is to get a good history. We have to do a good examination, is find out what exactly the issue is. And we do something called the biopsy. Basically, we take a small chunk of tissue, we send it to the lab, and we find out what exactly this issue is. We also have to do a couple of other tests. It could be an MRI of the abdomen and pelvis. We may ask for certain additional tests, such as the CT scan of the chest or a chest X-ray. But when we feel that the cancer is the growth is slightly large and it appears a little advanced, we may ask for a scan called a whole body PET scan. So this is more and more often, most of us have started moving into asking for a PET scan to diagnose. So once we have all these information at hand, we'll be able to kind of pick out the nature of the disease and what exactly is the stage in which this patient presents to the OPD. Yeah.
So we know that the treatment option is based on the staging of the cervical cancer, sir. So what are the treatment options available?
Yeah, so as Jayanth has rightly said, I think taking a biopsy is very, very important. Somebody should not diagnose a cervical cancer without a biopsy. And rightly said, the imaging modalities which are available, like an MRI or a CT scan or a PET scan, should be used. Now, depending on all of this, plus a good clinical examination is something which is very, very important. So depending on all of this, you would stage a patient. So for stage 1, which is the early stage of cancer, and a selected group of stage 2A patients, where these are the patients where the disease has not spread outside the uterus, that is in the parametrium. Those patients need surgery is an option of treatment. It's very important to realize that just doing a simple hysterectomy, that is removal of the uterus, is not the treatment of choice. I mean, that would be an incomplete treatment. So we do a surgery called as a radical hysterectomy, where as per cancer principles, you need to remove the uterus. In addition to that, you also need to remove the tissue which is there on the sides. In addition to that, behind the uterus, there are these lymph nodes where these cancerous cells can go. So as a part of standard surgery, they also need to be removed, which is called as a pelvic lymph node dissection. So all of these, this needs to be done as a part of standard surgery, and then it needs to be sent for a detailed histopathological examination as well. Now I would just like to add one thing in addition to that. Now previously, prior to 2018, we were also offering to do these surgeries by newer modalities like laparoscopic surgery or robotic surgery. But since there is a large trial which has shown that doing laparoscopic surgery or robotic surgery, especially for cervical cancers which are more than 2 cm, the survival is inferior. We have stopped doing that. So we are offering only open surgery to these patients, because at the end of the day, as treating oncologists, it's important for us to not compromise on the patient survival at any point of time.
So what are the treatment options available for a advanced stage, locally advanced stage, or when surgery is not possible?
Yeah, so I think the locally advanced cancer is basically anything which has spread beyond the cervix, uterus, if it's going into the parametrium, the side, the sides, the tissue on the sides of the cervix. Also, if it is involved in any of the lymph nodes, then it becomes locally advanced. So the treatment of choice in these cases would be radiation therapy, along with weekly doses of a very mild sort of chemotherapy. So radiation therapy is basically the use of X-rays or some kind of ionizing radiation. We treat the disease that we're able to see at the time of examination and also on the scan. We also treat areas where there is a risk of having disease. So radiation is a very quick procedure. It's painless. It's about 15 minutes per day. We give it 5 days a week, Monday to Friday. There's no treatment on Saturdays, Sundays. This will be in addition to tiny doses of chemotherapy that's given once a week. So treatment usually goes on for about 5 weeks. And after this, we do something else called brachytherapy. It's not invasive. It's not like a major surgery. It's just we place the radiation source in very close to the cervix, and we give a slightly higher dose of radiation, and the whole thing is usually done in about 8 or 9 weeks time. So that's the standard. Just for completion's sake, even in early disease, once surgery is done and we have a look at the histopathology report, we would go back and look if there are any risk factors. If there are no risk factors, surgery, that's the end of it. They just need to come for follow-ups. But if there are some risk factors on the biopsy report, we may have to follow that up with a milder dose of radiation. Yes. So, yeah, that's just for completion.
I think in addition to what you mentioned, it is important for the audience to know that even in advanced stages of cervical cancer, with proper radiation techniques and proper chemotherapy, cure is still possible.
Yes.
And the control rates are definitely good. The cure rates are good. So just because somebody has an advanced cancer, all is not lost. And still, because technology has advanced, good cure options are still available.
Yes. I think with all the newer modalities in radiation, we've seen patients coming even with stage 3 and some sort of stage 4 cancers. They're coming back even 8 years later, 10 years later.
Absolutely, and which is quite gratifying as an oncologist.
Exactly.
So there are fully functional, cervical cancer screening protocols in the developed countries, but it has not yet been, it's not happening in India as of now. So
yes.
What about the role of screening in India, and what should we do to?
Yes. So unfortunately, as of now in India, we don't have any developed screening protocols. But if you ask from a public health point of view, screening is the single most intervention which will reduce mortality. Cervical cancer is like a model disease according to the WHO classification. That is, it is preceded. That is, before somebody gets cancer, there is a long pre-cancerous phase where it is nearly lasting for about 5 to 7 years. And we have tests by which we can detect this pre-cancerous phase. And if somebody is offered treatment in these situations, the cure rates are nearly 100%. So there are very simple tests which somebody needs to do, like a pap smear or a HPV DNA test or a visual inspection with acetic acid. They are available with any general gynecologist, and it is just a very simple OPD procedure. One needs to do, somebody who is above the age of 21 or who is sexually active should do any of these tests at least once in 3 years. That is what is recommended.
So can you tell about the vaccines available for HPV?
Yes. So this is also something which is developed in the last 5 to 6 years. As I have discussed, the cervical cancer is caused by a virus called as the Human Papillomavirus. The common types are 16 and 18, and we have a vaccine against them. Now it is very important who should receive the vaccine. It is important to give the vaccine as early as possible. The recommended guideline is to give it between 9 to 13 years of age. Now why that is important? Because the vaccine will act best if it is given before somebody is sexually active, that is before somebody gets infected with HPV infection. Also, there is also one point which I would like to make. Just because you have an HPV infection doesn't mean that you will get cancer. It is just 0.001% of the individuals who have HPV infection will go on to develop cancer, but that is over 8 to 10 years. So it's important for somebody to take vaccine as early as possible. There are different vaccines available in the market. Most of them need to be given in 3 doses. And also it is important that after somebody has taken vaccine, screening should still continue. That is, you should still continue to do your pap smear or your HPV DNA test, because vaccine will protect only against 70% of cancer. So you need to continue screening even if you are vaccinated.
So any girl child at the age of 9 to 14 can be vaccinated?
Yes. They now it is said to be quite safe, and we need to take, they can take vaccination.
So now let us discuss about the endometrial cancer. So what are the risk factors and symptoms of endometrial cancer, sir?
Yes. So of late what we are seeing is there has been a steady increase in the incidence of endometrial cancer. Primarily the risk factors or the reasons for this increase is a tremendous explosion of epidemics of obesity, hypertension and diabetes. So these endometrial cancer, especially the type 1 endometrial cancer, is associated with these three you can say comorbid conditions. Also anything which is causing excess estrogen in the body, maybe obesity, or somebody might be on hormone tablets, or somebody might be having PCOD, that is polycystic ovarian disease, for long times. Also somebody who has taken treatment for infertility. All of these reasons are known to have an increase in the endometrial cancer risk.
Okay. So again, for evaluation and of this patient, if the patient comes with symptoms, what are the things we should be doing, sir?
Yeah, so usually patients will come to us with complaints of abnormal bleeding. Most of them are in the perimenopause or postmenopausal age group. So they'll come to us with complaints of bleeding. Occasionally they may come with complaints of pain abdomen. So what we would do is again a good examination. Most important test in this case would be an MRI of the abdomen and pelvis. We may follow this up with a CT of the chest. Like in other cancers, the most important test to be done will be the biopsy. In some cases, we may do it at the time of surgery, but the biopsy is also very important.
Okay.
Yeah.
Absolutely. There's just one difference between endometrial cancer, which is the cancer of the uterus, and cervical cancer. Unlike cervical cancers, fortunately, most of the endometrial cancers present to us in early stages, primarily because the main complaint is bleeding after somebody has stopped menses.
Yes.
So any postmenopausal bleeding or bleeding after menopause should not be neglected and should be investigated, as how Dr. Jayanth has stated.
So what are the treatment options available for endometrial cancers?
Yes. So as I said, that after the investigations are done, including imaging, which is most of the times an MRI scan, this patient should be offered surgery. So surgery, if the tumor is limited to the uterus, then hysterectomy is the treatment of choice, along with the removal of the lymph nodes, which are the pelvic nodes and the para-aortic nodes, which is a little above, that is on the sides of the aorta. So unlike cervical cancer, where only a pelvic lymph node dissection is needed, in this case even a para-aortic node dissection might be needed in some cases of cancer.
Okay.
Now, as far as the newer techniques are concerned, endometrial cancer, or the cancer of the uterus is probably one cancer where there is definite evidence to offer them minimal access surgery, that is either a laparoscopic surgery or a robotic surgery. Now, as we know that more and more obese patients are getting these cancers. There are more patients who are having other comorbidities like diabetes, hypertension. Some have heart diseases. Some have hypertension for long periods of time. All of this, in fact, minimal access surgery like a laparoscopic surgery or a robotic surgery is more advantageous because the pain is much less. The chances of infection are less. The patient recovers quickly, and we can start feeding the patient early. We can discharge the patient early. The blood loss is much less. So overall, the recovery is also quite fast. Also, most important is in some of the patients, we might have to give additional treatments like radiation or chemotherapy. Use of minimal access treatments like robotic surgery or laparoscopic surgery, they increase the recovery time. That is, they hasten the recovery period so that adjuvant treatments can be given as early as possible.
Apart from surgery, what are the other treatments which might be needed in treating an endometrial cancer, sir?
Yeah, so this will be very similar to what we've already discussed. So surgery will be the main treatment option. After surgery, we will send the entire specimen to the lab. A detailed examination will be done, and finally, based on the histopathology report, we will be picking out if there are any risk factors. So we look at a number of things. We look at the age, we look at how much of the uterus muscle is involved, and a whole lot of other factors. So based on these, we will then decide if the patient needs to receive any further treatment. So if they are in the low risk with absolutely no risk factors, surgery, that's the end of it. They just have to come for follow-up. But if there are a few risk factors, they may need some additional treatment in terms of radiation. So radiation, there are two types. One is brachytherapy. It's absolutely painless, just 3 or 4 sittings. That's the end of their treatment. In some patients, when they have a few more risk factors, we may offer pelvic radiation. This will last for about 5 weeks. Similar to the advances in surgery, we also have a lot of newer techniques in radiation. So we have something called the image-guided radiotherapy. We have something called the VMAT, which is the volumetric modulated arc therapy. The chance of having long-term problems with the bladder or the rectum or the intestine is very, very low. We've hardly seen any patients come back with long-term complications. There may be a few patients who may require a chemotherapy after surgery, but this again will depend on what sort of risk factors they have.
Okay.
I think what has happened in basically in oncology treatment is because of good amount of research and better technology, surgery is getting more better, our morbidity is going down, radiation techniques, machines are getting better, so that the previous side effects which used to be there, say 20 years back, are not there, and we are giving a much better quality of life to our patients. And I think side effects have substantially reduced, and also the patient's ability to tolerate treatment also has increased because of this.
Absolutely. Yeah.
So for a family which has a person with endometrial cancer, so should they undergo any genetic testing?
Yes. So unlike ovarian cancer and breast cancer, where the risk of somebody having the disease because of a genetic risk is around 25 to 30%, there is about the 5% of patients who have endometrial cancer might have a genetic risk. So this is mainly known as the Lynch syndrome, where somebody has an increased risk of endometrial cancer. They also have the increased risk of colon cancer. So if somebody has got a cancer we don't routinely test patients for Lynch syndrome, but only if somebody gets cancer in the very early ages, say somebody who has cancer under 40 years of age, or somebody has a family history of either a gastrointestinal cancer or an endometrial cancer. So we do test them for Lynch syndrome.
Okay. So what are the newer treatment options available in the Gynecology, sir?
Yes. So in addition to the cervical cancer and endometrial cancer, which we commonly see in practice, the other common cancer which we see in our practice is the ovarian cancer and the fallopian tube cancer. So there are a lot of newer advances which have occurred. Primarily, one is the surgical advance, which is called as a Cytorotative Surgery in HIPEC, which is mainly has some good survival in some types of very advanced ovarian cancers. So there what we do is the patient undergoes a very aggressive surgery where we do a procedure called as a total peritonectomy, where the total peritoneal lining of the abdomen is removed, because we believe that unlike cervical cancer or unlike endometrial cancer, ovary is a peritoneal disease, so which more or less spreads to the peritoneum. It also involves other parts of the conventional surgery like a hysterectomy, removal of the ovarian tumor and the lymph nodes. In addition to that, as I said, we do a total peritonectomy, plus we might have to do an intestinal resection also sometimes. After all of this procedure is done and you have achieved a total tumor clearance, that is something which we call in medical terms as CC0, we put chemotherapy inside at a higher temperature and higher pressure. The logic behind this is that the chemotherapy will penetrate more better at a higher temperature and higher pressure, and it will be delivered exactly to the target site. And there is some data definitely to show that in some types of ovarian cancer, there is a definite survival advantage if you offer this type of treatment. The other advance which has occurred is mainly in the form of targeted therapies. Now, what has happened, as I discussed with you, about 30%, 25 to 30% of ovarian cancer patients do have a genetic, they have a mutation in a gene called as the BRCA gene. So these patients, they are responsive to a particular drug called as the PARP inhibitors. Now they are available in the oral form, so you don't need to take chemotherapy by needle pricks every time. You just have to take a tablet every time. You can be at your home in the comfort of your environment, take the tablet. The tablet has minimum side effects, and in individuals who have a BRCA mutation, this has shown a significant survival advantage of more than 5 to 6 years over the conventional treatments if somebody takes this treatment. In addition to this, there are many other targeted agents which are also coming up, and overall in all cancers, not just in ovarian cancer but also in some types of cervical cancer and more recently in endometrial cancer, there is a lot of role of immunotherapy which is coming up, very promising role, and we hope that the future is quite exciting, that we revolutionize cancer surgery and offer our patients a better survival and a better quality of life.
So, hope this session was useful, and I thank Dr. Rohit Ranade sir and Dr.
Thank you.
Jayanth Bhargava sir.
Thank you.
And wish you all a very happy and healthy life. All the best.